Greetings and welcome. We are here today coming to you from Philadelphia Fight. And the topic at hand is vaccine hesitancy in the Black church in particular. I'm Calenthia Dowdy, and I am the Chief Faith Officer. And we're going to talk today with three local pastors who have direct experience with vaccine hesitancy and going to share some of their wisdom with us and some of the things that work. So we want to look at why there's hesitancy, particularly amongst Black people, what can be done, what are we doing, and what has worked. So we're going to just talk a little bit about each of those things. But first, let's have each of our pastors introduce themselves. Let's start right here with Bishop Dwayne Royster. Tell us who you are and your church connection and all the other things.
Great, thanks. I'm Bishop Dwayne Royster. I serve as the Executive Director of Power Interfaith and Power Action Fund, and also as a pastor for 31 years, and most recently serving Faith United Church of Christ. And then I also serve as the founder of a group called the Society for Faith and Justice.
I am Donna Jones. I serve as the pastor of the Cookman Beloved Community Baptist Church, as well as Executive Director of Metropolitan Christian Council of Philadelphia.
I'm Leslie Callahan. I serve as the pastor of the St. Paul's Baptist Church here in the city of Philadelphia. And I'm not the executive director, so I feel like I'm underperforming.
You're healthy.
Except we all look to you.
Anything but underperforming.
That's right, absolutely.
That's for sure. All right, well, welcome. So glad that each of you could be here.
Thank you.
So in looking at the statistics, about anywhere from 75, maybe 78% of the total population receives some element of the COVID vaccine, at least one dosage. Many got one shot and decided they weren't going to get any more. But so they total those numbers to about 78%. 59% of Black adults got at least one shot of the COVID vaccine. Those numbers are extremely low, certainly in terms of folks of African descent who got the vaccine. And I think the first question is why? Why do we see such hesitancy amongst Black folks in particular? Anybody? Jump right in.
One reason is a mistrust of medical community at large. Mm-hmm. And then we can add a mistrust around vaccines in general. Mm-hmm. And then there's access. Mm-hmm. So, and I think if I were to put it on a graph, mistrust would be here, access would be there. Mm. So being able to get the time, the energy, whatever it took, even though the vaccines were free, it still took some access issues to make that connection.
Yeah.
Yes, I was actually going to start with access too, because I think that was a big problem. We saw it here even in the city of Philadelphia. When the vaccines rolled out initially, you had to have the capacity, you had to have internet, you had to have a certain level of facility in finding spaces, and quite frankly, that's still true. I got boosted recently with the updated booster. And finding a place that actually had the vaccine, had it that day, had it available, a time slot, your zip code. I mean, it's actually still not entirely easy. So I think access is a big part of it. I also think we have to credit the misinformation campaign.
Yeah, I was going to say that. Yeah, absolutely.
There are the people who know a lot, and then there are the people who are fed information and come to feel like they know things that actually aren't true. Yeah. One of the, I think, general tragedies that happened around COVID was the amount of politicization over the basic requirements to keep oneself safe, to mitigate risk, etc. We've seen the politicization of masks, we saw the politicization of the vaccine, and on top, and I think that's an access issue as well, people were told lots of things, and some of the things were not consistent about whether the vaccine would be available, whether there would be a cost. what it meant to register your kind of personal information in order to get the vaccine. I think all of that. In addition, I think suspicion. I think suspicion is warranted.
Yeah.
And I think that the powers that be did not deal with suspicion terribly well, which only exacerbated the misinformation and the suspicion.
Yeah, I actually had a member of my church that, so there was some confusion about the face mask in the very beginning. And the confusion really was like, do you face mask? Do you not face mask? People were like, oh, face masking is bad. You shouldn't do it because it keep, And so eventually they got to the place where they were face masking. So I literally had a member, because I got up in church on Sunday. I mean, we were virtual at this point, but got up and said, you need to wear face masks. And this is the reason we need to do that. Literally next day in the email, she sends me this misinformation piece about why wearing face mask is bad and all the problems that it's going to cause you, which really was, in many ways, I think, kind of a extremist, a political point about why we shouldn't wear a face mask. But she sent it to me anyway. She's like, I'm not going to wear a face mask. And it took me months to work with her to get her to the place where I was like, where she was willing to be like, oh, I understood this. She understood, but there was that misinformation. It was very real. It was prevalent in our community. I think people still point to Tuskegee and, wondering like, is this an experiment on black folk again? And, I had family members that were sort of like, I'm not getting that. They're experimenting on us, and having to work through all of that to try to get them to a place where they felt like it'd be safe. I mean, when everybody else got it and there were no super bad effects, and then they were like, oh, I guess it's safe. And I mean, for some people it's like that. Some people aren't early adopters, right? They're not going to adopt early. They got to wait and see what other folk are going to go through, how they're going to respond, and then go from there.
There also was, I mean, as you're talking about specific members of your congregation, I also had members of my congregation who just don't do shots.
Right.
And so, and probably, if I'm honest, as I think about it, the people I know who didn't get vaccinated, there was pretty consistently a fear of shots, specifically. And so I think also the method of distribution played some role in, you don't know what you don't know what they're injecting you with, but it was also that they're injecting you with something was also a part of, I think, certainly that hesitation for people, and some folks never did it because. So
if it were a pill, maybe more people would have.
Yes, or something up
nasal,
one's nose.
Nasal,
I mean, there are various methods of distributing things. I think that not having, I think that was part of it. The fear of needles.
I'm sitting here chuckling because I'm afraid of needles. I know I'm a big guy, but I'm definitely afraid of needles. And my sister actually went with me. I was talking about my sister. My sister went with me to go get the shot. And I got the shot, and I was sitting there like, but there was more trauma caused by my anxiety than was the shot. The woman gave me, I didn't know I got the shot. She walked to the other car. I'm like, okay, I'm ready. And she's like, you're done. And I was like, oh, okay. But my anxiety was so high because of, more the needle than anything else. And then this little tiny needle, it's really quick. You don't even really feel it. And it was, once I got past that hurdle, I was like, oh, this is nothing. We just need to get these shots and get moving so people can be safe and whole. So.
Yes. The other thing that I saw was that as they did more and more boosters, so we did the work that that first level of people, they got the shot, and then it's like, okay, now you need to get another shot, and there was a lot of confusion around, was it going to be Pfizer, was it going to be this, was it going to be that, and it just seemed like every other minute there was just another shot you had to get, and so folk were like, all right, that's it, I'm done.
Yes.
I got a shot. And they promised, because we would talk to people about masking and all of that. So they're like, I got a shot, I'll wear my mask. And the mask was like under their mouth. And
their nose was exposed. Yeah, absolutely, yeah.
But there was a response of, it would have been good if they could have said, this is like the flu shot. You have to get it every year. It's like hepatitis B. You get it now. If they had said that in the very beginning, that could have helped with some of the issues we had with people getting boosted. because it took a lot to get people to get the shot. They had to work to get the booster. We also had issues with when it was made available for children.
Yes.
Oh, yeah.
A lot more hesitancy as those ages got to be less and less.
Yeah. Well, I think certainly one of the issues was that there was so much we didn't know.
That's right.
Certainly as the general public, but medical providers as well. So when I heard that there would be boosters and things like that, I was like, oh, this is new info. You know, I get my one shot. It was new info.
So
yeah.
And that also speaks to, I think that's another reason for hesitation. I think at the beginning of the COVID crisis, I think there should have been more conversation about the novel part of the virus.
Of the name of the virus,
Right.
exactly, yeah.
That I think and at the same time, I think that was also part of the hesitation. I think there was a lot of confusion about mRNA technology and the idea that it was new. We've watched drugs come to market. It is not typical for something to be identified in December one year, and for there to be a drug that comes to market. The first vaccines were being given out in December of the next year, in December 2020. I got vaccinated the first time in January 2021. I think the sense, how did they do it this fast? I think there were some reasonable questions, and I think I've already mentioned that I was a bit frustrated with the rollout and the PR around it, because I don't think that our government did a very good job in kind of distinguishing between reasonable questions that people had and just kind of conspiracy theories. The other piece is, when they did roll out the vaccine, this is to your point, Reverend, they rolled out vaccination as the cure to the problem.
Yeah.
And if you recall, when we got vaccinated, and there was like a 2 or 3 month period before the Delta variant came out, where they were like, you're good.
Yeah.
If you're vaccinated, you're not going to get COVID, or you're extremely unlikely to get COVID. Not only, they didn't treat it as a mitigation factor, they didn't manage expectations around it. And some of this, we should have known, because of the behavior of viruses in general. It is very rare for a virus to be eradicated.
Yeah.
So the idea that if we all get vaccinated, we can go back to normal, which was supposed to be the draw for vaccination, ended up, I think, being a double-edged sword, in the sense that it gave people false expectations on the one hand, and it also made people more suspicious about the technology on the other. And we're not, let's be very honest, and this is not a black thing, we're not a terribly scientifically astute. I mean, look at who was the president.
Yeah.
I mean, so we
got to talk about that, right?
Yeah. No, I think we do have to talk about. So were black people suspicious of something that the government produced when the worst president we have ever seen was the president?
Yeah.
Yeah. And reasonably so. And I feel like we could have taken that part. We should have taken that part more seriously. And your point even about the masking. If they had said to us in March 2020, don't buy masks because we don't have enough of them, which is really the reason why they were discouraging masking at the beginning, is that they were afraid that they wouldn't have enough of the personal protective gear for the people who had to be out. If they had been more honest about that, instead of telling us, instead of kind of minimizing the usefulness of masks, I think we would have had less problems of the sort that you're describing later on. And once we realized that, so I'll say this emphatically, and then I'm sure you have other questions that you want us to attend to. Black people have very good reasons to be suspicious of anything that happens in the United States.
Period.
Period. We have very good reason. And even, you mentioned Tuskegee. I mean, people don't remember the details about Tuskegee. They don't remember that the Tuskegee experiment was about withholding care, not introducing syphilis. That's not actually what happened. They weren't.
Right.
Syphilis wasn't introduced through the Tuskegee experiment. They were withheld the care that was available for the curing of syphilis.
Right.
But people don't remember that. And heaven knows, there's certainly been cases of the bodies of black people being experimented on.
Absolutely.
Pretty much every scientific development in the United States medically has involved some group of black people having their bodies experimented on. I'm sorry. So I think we need to be honest about that. And I think more information for our congregations was and remains the key. And it did help, as you said. I mean, I videoed myself getting vaccinated.
Yeah.
I put it in
I did the same thing. Yeah.
I put it in the service.
All right. That's my
so-
next question.
So, I mean, I think I did a lot. I mean, not knowing was the problem. Providing information
Yeah.
was the solution.
Yeah. No, that's wonderful segue because there was a lot of talk about modeling, right? So, I mean, they were bringing in medical providers who were African American. One of the women who created the vaccines, a woman of African descent, I think she
Yes,
was
that's
African. And so just this idea of modeling, if the black community sees other people, in this creation and encouraging, what kinds of things did you all do in your churches? Dr. Callahan, you said you videotaped yourself.
So I both shots. So I was doing. We were still virtual, totally virtual at the time, and so I was doing these COVID-19 segments on a fairly regular basis. I had a friend who's an epidemiologist, and I would at Thanksgiving we did a video like, okay, what should we be thinking about? Should we be with our elderly relatives at Thanksgiving? And at that year, the answer was no. Smaller gatherings, whatever. And so I had been doing these things for months then. And so when the time came, when I got an appointment kind of unexpectedly, my daughter and I were out, and I heard there were extra vaccines someplace when they first rolled out here in Philly. And I was like, I can get there. So my daughter was with me. She took the phone, she videoed me getting my shot, and I put it in the service and sort of described, and I brought my epidemiologist friend to explain how an mRNA vaccine works.
Yeah.
That's good.
Yeah.
And that was super helpful. So I think more information was helpful. That's one of the things. And we did more kind of informational pieces, like this is what's going on now.
Yeah, like we similarly put it on Facebook, and I don't do a lot of Facebook, as Calenthia knows, but I did put it on Facebook when I got the shot. I did send out the group text, got my shot kind of thing. We also, I think this was a week, it was more than me doing it, but calling people, so people who were expressing concern, just calling and say, did you get your shot yet? And stopping to listen to why they didn't get a shot. Took some people to get their shots. Took more people than I even care to think about now to get their shots. But that also that allowed us to, I guess, emphasize. So I know there was one young man, he was like, no, mRNA is going to make me sterile. He had like a billion reasons. So it was just really
hadn't heard that
a lot of,
Oh yeah.
I remember that one. Yeah, I remember that.
was a good one.
I heard sterile impotent.
Impotent.
Who was
the
it?
other one.
The rapper.
Some famous guy.
Yeah, the rapper whose cousin, somebody.
Yeah.
There was always something like that. Yes.
Yeah. And so just having the conversations often. And then I know with that one guy, I was like, look, I'm going to take you. I will take you there. I will sit there. You'll be fine. So it was really the ministry of accompaniment to the max. But mainly it was just constant. I have a small congregation, so bugging is something that we're able to do. But it was a lot of bugging.
Did you get your shot? Did you get your
Did you
shot?
get your shot? Why didn't you get your shot? When are you going to get your shot? I don't know where it is. Well, I'll take you, all that.
Yeah, I mean, I sort of missed the first shot because I didn't realize she did it. My sister was had the camera up, but I'm a big guy. I was blocking so they couldn't see the nurse with the needle. So that was pretty funny, actually. But we got information from the city we were giving out to the members. We were sending it out. I preached about it. I talked about it. And in a lot of services, a lot of sermons, I was very clear about this moment. And I was also clear that medical science is not antithetical to faith.
Right.
And had to spend a lot of time having that conversation and in particular, I had a person on my ministerial staff that was telling people to use natural remedies. And I had to really spend time counteracting that because that was the thing too. Everybody's like, you can just use these natural remedies. I'm like, no. And so we had to, spend time kind of unpacking that, bring that about, helping people understand that, no, you actually need this shot. And then talking about the experience. I mean, I talked about, what side effects I felt, things that I did. When I went back to the second shot, it wasn't as bad as the first one. And then the booster that I got later on, I really had minimal impact, one way or the other. And, I even had to talk about my own anxiety and all that too, right? And how the anxiety probably heightened what I was experiencing in the first shot. So, I think there was a level of vulnerability in that. I talked about the fact that I tried 4 times to get the first round, and I couldn't get it until late March. I showed up at places that run out of vaccine, different things. I got invited to be a part of a clergy team that was doing this, and before they got to me, they ran out of the vaccine. And so I kind of talked about my own sense of desperation about wanting to get to this because I thought about my family. I wanted to be here for them. I wanted to make sure I had ill relatives. I needed to make sure that I was available to them as well. So there was a lot of vulnerability that I had to enter into space, which I'm not accustomed to entering into, to really, kind of help people get through some of their stuff around the vaccines. And then, later on, it became a challenge when we finally decided to start coming back into space, where the congregational governance body decided you had to show your vaccine card to get into the building.
Yes.
And that, I think, also pushed a lot of people. Like, we were taking it so seriously, so now it wasn't just me talking about it. Our congregational governance body was basically saying, we call the Ujima Coordinating Council, was basically saying that, no, we want to respect each other enough that to be able to come back into space, you need to have this shot done.
Yes.
You need to have at least 2 and 1 booster, and that's what we were working with. So it was a lot of education, a lot of stuff that we were doing. We used a lot of the stuff that came from the city to be able to talk to the members of the congregation and get them moving from there.
Good.
I want to add on to that. We did the same. Our official board, which is our governing body, we created a policy that anyone who represented St. Paul's had to be vaccinated. This was before the boosters. That they had to have completed whatever the vaccination process was going to be. If they were doing the mRNA versus Pfizer or Moderna, they had to have had 2 shots. If they were doing Johnson & Johnson, of course, they only at that time had to have 1. And we asked, and that was both for staff and volunteers. So anyone representing St. Paul's had to be vaccinated. When we first started to come back to in-person or hybrid gatherings, we required registration, and part of the registration was the vaccination card. So we also, now I will say by then, people were just showing us vaccination. The folks who were vaccinated who were going to be vaccinated by and large had already done so. And I think that had to do with, we had a Zoom call. We used to do a Zoom call early in the pandemic. We did it every day. And so when the vaccine, so that was the point where people could sort of talk about how they were actually feeling. We'd come in and just mostly just kind of check in, like, how you doing? And so these questions about what the vaccines are and what do you know about it, and kind of a clearinghouse for that kind of information happened in that space. And so people, it almost became a badge of honor. I got mine, kind of thing.
Yeah.
Yeah.
And they were, which goes back to the access thing. they were in short enough supply in Philadelphia that there was a time where you felt very privileged if you had
Yeah.
gotten one.
That's right. Yeah.
So I think, again, back to this
Yeah.
question about how come people didn't.
Mhm.
By the time they were
find it.
widely available, you know, I think people who were disinclined might have felt like, well, I'm good now. Some people already had ended up having COVID by then,
Yeah.
by the time they were widely available. And so they felt, somewhat reasonably, that they had their experience and had the immunity that came from having been infected. So I think access is I want to just co-sign access again.
Yeah.
Yeah, and the other thing that happened, which wasn't us, it was really in the world. We talked about the negative campaigns before, but the other thing that influenced my group was they worked in jobs that were saying in order to come back,
Yes.
you have to have a vaccination.
Yeah.
That's
Yeah.
right.
And these were folk that didn't have the privilege of saying, well, I won't go back to work, I'll get another job. They were like, oh my gosh. So that pushed people over.
Yes.
That whatever edge was left,
That's right.
that was like, I guess I have to.
Yeah.
So so when the employers started to require that you had to have a vaccination, our challenge was
We did that.
getting people after they got the first vaccination to get not only a booster but to get boosters.
Yes.
So that ended up still being please get the booster, please get the booster. But and then after the second booster, I'm sorry, as a pastor, I was like, okay, I can't keep pushing y'all
Right.
to get the third, the
You gotta
fourth,
own
the
it.
fifth.
Yeah.
Right.
So I did get to that. Okay, I've done what I can do. You got your one, you got your two. We'll pray from here on out.
Yeah. Yeah.
In that way, it's much. In that way, it is like the flu shot or the pneumonia shot or the.
Yeah.
I think the people who tended to be. What I would like is for the rollout to be more consistent, so
Yeah.
that the flu shot and the next booster come at the same
Yeah.
time, which makes it a little easier
Yeah.
to feel like you're in a cycle. But what I find now is that the people who get boosted are the people who go to their doctors regularly.
Yeah.
Sure.
Yeah.
Yeah.
The doctor
And
said.
so at some point, I agree, at some point it stopped being, at some point we stopped requiring proof of vaccination. Those things changed, but I think the early adoption really did have to do with creating a space where people actually talked about why the people who were getting vaccinated talked about why they were getting vaccinated. The people who had questions could bring them. If we didn't know the answer, we brought people who did understand and who could sort of offer more a fuller explanation
Yeah.
to counteract again so much of the misinformation that was out
Yeah. And there was ample.
there. There was.
So we are, Philadelphia Fight is a federally qualified health center, and I think one of the things we said before everybody returned to work was you have to get your vaccine unless you have health or religious reasons for not getting the vaccine. But certainly all of our medical providers, folks who work directly in clinics, certainly had to have them. I think we really try to work at and figure out how we can work more closely with faith communities, because pastors have a lot of influence on their people, for better or for worse, a lot of influence. And part of my job, quite frankly, is around educating pastors as it relates to HIV and so forth. But certainly in talking about things like COVID and other viruses and so forth, and how we can work together, how faith communities and medical providers can work together to encourage and to, quite frankly, to love and to nurture our communities. And what kinds of ways, and you might have some ideas that certainly I can use, what kinds of ways might we work at that kind of partnership as clergy and health providers? And I sit in the middle of that, right? Certainly as a clergy person, but also as a person who works with medical providers.
I think a theme that's been running through is the theme of relationships. I mean, pastors have influence insofar as people trust us. They trust us because we attend to them in certain ways and at certain times of life. I think all of us who've told stories about people deciding to be vaccinated or whatever tell it in the context of the relationships that we have with the people driving them, like, or talking to them, or educating them, or I think the key issue is for the institutions and the providers and so on who have medical information to develop and nurture relationships with clergy and vice versa, and then for us to use our care for our congregations as the reason behind whatever it is we're offering in terms of our counsel. We focused a lot on, I think you've heard this theme in the conversation, we focused a lot on caring for ourselves and for one another. Our commitment at the beginning of the pandemic was that we were going to do everything possible to provide care for one another, even if that care meant that we couldn't be in the same room together. And
that was hard.
It was, but it also made us super creative. We've all had to be creative. And the truth of the matter is that we sometimes took for granted that we were providing care just because we saw one another before the pandemic. And it turns out we didn't actually know one another that well, and we weren't actually doing life together. We were seeing one another in passing. And now I don't take for granted that just because I saw somebody that I know what's going on with them. And so I think the building of relationship, the hearing of one another's voices, that's sort of like, are you really good? Or are you just saying you're good? I think that's the source, the relationship building on every side of this. With providers, with people who have information. We remain wildly uninformed about the state of HIV awareness and understanding about science around HIV and suppressants and so on. I still don't think, those of us who came of age at the onset of AIDS, I think we still don't know all that we need to know. And then we need to figure out how to pass on that information. But that's all relational.
Right.
But the other thing that did happen, I think, that also includes the faith community, is that physicians started to build relationships with faith communities. So when I was struggling with how to help my parents help their kids, to get vaccinated, there's a physician I know who's a pediatrician, but he's a physician I was not in relationship with. He's a West Philadelphia physician. So I had this issue, so I called. I was like, all right. So he's like, okay, don't worry, I'll get on a Zoom with your parents and answer their questions about the vaccine so that they can feel comfortable. Well, we've stayed in relationship.
That's great.
So now we've got the RSV vaccine and this vaccine and that. He's like, Dr. King, So I think that the growth of relationships has been a positive outcome, and relationships of congregations with the medical profession has been a positive outcome.
That's good.
And I think that also out of organizations that are on the medical side, the intentionality that we started to see about getting information to us, whether it was on a church fan or a bulletin insert, or there was more conversation going on, how do we serve the church, from physicians and nurses and healthcare providers. So we ended up with information that not only helped us then, but as we look at what's needed now we need some things that kind of inclusively talk about vaccinations.
Yeah,
absolutely. Absolutely.
Yeah, I think for my experience has been that there were medical facilities and there were congregations, and their relationship was very transactional. You show up at our event, we'll give you the mic at our event. And, you know, and it was really the way that it was going down.
Yeah.
I mean, most recently, we just had a thing, Faith Church, one of the universities has a medical school, sent their team. They're now talking about setting up a clinic in the church, which would not have happened had COVID not happened, right?
Right.
And they're looking about building long-term, more sustainable relationships in minority communities and providing services in that area. And I think, like I said before, we would go, they would have open house. They're like, oh, could you come off for a prayer? You know, we would have something, a health fair. Would you do a table? And that was really about it.
Yeah.
Now we're like really strategizing together. And I think that's really what it is, because in many ways, what we do and what they do is the same thing. We're caring for people.
Yeah.
Whether it's their spirit or their soul, or we're caring for their physical body, and sometimes it's an intermix of both.
Yeah.
And so I think my experience has been that medical professionals are more open right now to saying, how do we do this together? And it's not, you know, it's not a big I, little you. It's like we need everybody to be able to work this together, to be able to help take care of folk, and to be imaginative and creative as we move forward. And so my hope is that we'll be able to find ways to do more and more of that, more deeper partnerships that allow us to think creatively about how we really minister and take care of community. Because that's really what both segments of those industries, whether it's clergy or whether it's doctors or nurse practitioners or physician assistants, we're all charged with the same responsibility about caring for community.
That's good. I like that. Absolutely. Philadelphia Fight opened up a clinic around the corner at Broad Street Ministry, which is no longer a church, but I think it was when we started over there, and so that's been rich. That's been a rich partnership, but I'm sure we could work at different ways of intensifying that even more, for sure. I'm wondering about, certainly the Black community generally has kind of lower health literacy. And I'm just wondering, I think a lot of this conversation speaks to the education piece and what we could do, but certainly trying to think through even more that we could do as it relates to bringing up that health literacy. And I think a lot of that is connected to distrust of medical providers, particularly white medical providers. I don't know. What can we do about the lack of health literacy in Black communities?
And I think we also need almost like a two-pronged approach, because, you know, things get filled in the void. So there is a lot of spooky health literacy going on with alternative medicines and alternative solutions. And I think that I saw an uptick in that during the COVID that continues to rise. So before it was related directly to the virus, and now it's related to like all these other things. And so there's a moving away from overall trust in medicine and medical solutions.
There really is.
And I think we need more conversation, information to fill that void and say, you know, yes, holistic medicine is real, but it looks like this. Right. Traditional medicine is real, and it looks like this. Yeah. Whatever this is, we don't know. So, you know, I think there's a corrective space that we need to enter into now.
Yeah.
I also think, I would say I agree with that one. I think there's a different two-pronged approach that has to do with demanding that the medical establishment and medical professionals be themselves more astute about how to communicate with their patients, especially African American patients. Again, you know, I said some time ago that, you know, we have to acknowledge that the suspicions that Black people have of the medical profession are warranted. Those suspicions are real and warranted. Yeah. And I think one thing that would be helpful is that there needs to be better education and training for medical professionals around the treatment of Black people and the pretty clear evidence that racial bias, that racism has a negative impact on health outcomes for Black people.
Weathering.
So, okay, so we know this, right? And so we can keep asking Black people to fix systems they didn't create.
Preach.
Or we can engage in a two-pronged approach, which is what Black folks have always had to do. We've always had to make what we got work, even though it's not designed to work for us. But I think we can place more demands on medical professionals and on the medical establishment to be motivated by other things than profit, which is another dynamic in this. And to be motivated to have, to actually provide health care for people in general and Black folks in particular. At the same time that we, part of what it's going to require for us to be able to navigate the system that's designed as it currently is designed is that we are going to have to be more literate. And some of that is really, one of the things I appreciate and that we've done is to tell our stories. So we've been talking, we're talking more about Black maternal health and childbirth. Hearing these stories, here's how to know when something is going wrong, and here's how to talk to your doctor about it. Those kinds of spaces. Even things like I've seen on Twitter and elsewhere, okay, if your medical provider is unwilling to give you the test, then the one thing you can do is insist that they note on your file that they're refusing to give you the test. Because if there's one thing that medical professionals are afraid of is malpractice suits.
Yes.
And so helping, so it's sort of, it's multi-pronged. It's about literacy about the system, and then there's literacy about what health looks like, and what nutrition looks like, and what advocacy looks like, and so on and so on and so on. And and there's a theological piece to this too, which is, I want to say as a Christian pastor, we have to stop telling people that pain is for their good.
Suffering,
We need to tell people that when something hurts, that is a sign that things are not as they should be. So we need to kind of reorient our understanding of pain, in particular suffering more broadly, to help people to not just take for granted that their pain is because of aging, or that their pain is because, stop self-diagnosing, stop ignoring your pain, and if you have a physician who's ignoring your pain, then press them, because that happens as well. So I think there's so many, the more I talk, the more prongs there were.
Wow.
But I think number one, we have to ask that professionals do better. The medical profession has to do better. The medical system has to be better. They're the ones, we should ask the professionals to be professional first. And then we're going to have to do some things in the meantime.
I'm going to push on that a little bit and say we need to ask physicians to put people over profits, right? Because I think even when you talk about miseducation, some of the pieces that the language and nomenclature is really designed for white middle class people. It is not designed for working class folk. It's not designed for folk that are in poverty. I remember early on, Power had conversations with the City Department of Health. We were talking to them about working communities. We thought we were coming to them to hear what their plan was. And they came to us and said, "Can you all help us figure this out?" And I'm like, can we think that maybe we ought to think about the folk that struggle the deepest first when we're coming up with our plans? Because everybody else is going to get access. I remember early on that when they first started the vaccination sites, they put the big sites up. They intentionally put some sites in African American communities so people could have access, except our folk were standing in line while other folk from other communities were coming in and getting access to the. So can we think about the folk that struggle the deepest first? Because everybody else is going to get taken care of, right? And if we design our plan around that and not just talking to folk that have certain level of education, certain amount of money, and resources and ability to get around all these different places. I think they put stuff in Center City. They're like, everybody can get to Center City. I'm like, no, they can't.
No, they can't.
They can't. And
some of us hardly come to Center City.
Right. So, there was, I was kind of appalled at some of the decisions, but I recognize it's because they're not in relationship with folk that struggle.
Right.
Whether it's physicians or whether it was the Department of Health or whether it was the city themselves, they're not in relationship with these folk. And so they have no idea how these folk think, how they live, how they go about their daily tasks. I remember one of the things that came up was that they were like, we're going to send people door to door. And I'm like, you're going to do what? And I'm like, when somebody's knocking on your door and you live in certain communities, you don't know who they are. You're not opening that door.
Oh, absolutely.
You're not going to open the door. You don't feel safe, and you don't know what's going on. And so it was things like that we really had to work through. That it's misinformation, it's disinformation, it's a lack of caring about those that struggle the deepest. And definitively, to really change some of this, we have to ultimately change how we think and approach this. We can't always think about, I want to think about my average patient. I have to think about the patient who isn't coming. Yeah. Who's the person that's not showing up in the office? Yeah. Who's the person that's afraid to get the shot? Who's the person that doesn't trust the system? And then how do I language, plan, prep to be able to work with them, because everybody else is going to show up.
And the other thing on that.
So I want to say, by the professionals, what I mean is we know that medical professionals think that Black people don't hurt.
Yeah.
We know, we know
we have
that
great pain tolerance.
Yeah, we know they don't listen when we say something is wrong. I'm saying, if we know that they have that problem, then we could fix that problem before they actually start seeing patients. That's what I mean about asking them to act like professionals. Like, if you know that there is a problem in your profession, it's your professional responsibility to attend to the problem that you know is in your profession.
Right.
Right.
As opposing to wait for our advocacy around it.
Right.
Like, y'all, there's scientific studies that prove that this is true. Use your own science. Use your own studies. This is how y'all make discoveries this way. Discover a way to treat Black people like human beings.
But it's not profitable.
It's not profitable.
It's not profitable.
Well,
that's what the problem
and that's
is.
why I distinguish between the medical system and
sure,
medical
sure,
professionals,
sure,
right?
sure.
And you're absolutely right. I mean, we now have our medical system doesn't even work for middle class people. It works for it absolutely. It doesn't actually. I mean, if you can pay your way out of it, maybe you can make it work for you. But it's not actually designed to work for the care and health of anybody. It is designed to be profitable.
Yeah, but speaking of design, there's another piece that we don't talk about that the medical profession, pharmaceutical profession, and other professions we have to have conversation about, and that has to do with clinical trials.
Yes. Yes.
So when I was in the industry, we were always struggling because we couldn't get our people to participate in trials. And the bad news is, every antihypertensive med does not work the same with every ethnicity.
Right.
Period. But if you can't get more than white males to participate in the studies, how are you going to know? So back to that professional thing, it goes way into the Wayback Machine of how things come to market. And so if they're thinking about these things in the design stages, and they're also thinking about how to help people say yes to participating in trials, it's very difficult to do. But if they're thinking about it, they'll spend the energy and the time to think about, even if they're only thinking about money.
That's true.
We are some of the sickest people. So you're going to make some money if you figure this out.
Yeah.
But if they continue to give us products that they know don't work well for us, that means I'm going to go to the iffy stuff.
Yes.
Because certain antihypertensives don't work for everybody.
Right.
Certain things don't, women and heart disease, we don't present the same way and we don't respond the same way. So there are differences. How do we have those conversations that help with some of the other larger conversations that say, I don't trust? How do we become part of this partnership between the medical profession and the community? And sometimes something as simple as participating in clinical trials, the well version of them even. Yes, helps to just dispel some of the mistrust.
Yeah.
Yeah.
I agree. That's certainly, we can certainly learn something from the HIV community in that way. I mean, the line that I hear so many of our clients say is, nothing about us without us.
That's
Without-
right.
Right.
That's right.
Right?
Exactly.
And
That
they
goes
are
way
serious.
back. Yeah, and that goes way back to how you bring it to market,
Yeah.
how you design, I mean, when I was in the industry, we spent a heck of a lot of time designing how something was going to get put out.
Mm-hmm.
But we never did it with the people most impacted.
Which goes back to
Yeah.
Royster's
Exactly.
comment.
Yeah, yeah.
So, and then back around to the place where I seem to be landing. We have to have a conversation about the ways that some more conversation about the ways that what people are experiencing when they are taking these medicines gets ignored.
Yes.
I remember when I first started
Yes.
taking hypertension meds, they put me on one med and it didn't get us to where we wanted to be, so they gave me a second pill. And this particular medicine, my body just had a terrible reaction to. I would take it and a couple hours later, I would be almost non-functional. Like,
Wow.
it's like it was draining the life out of me. Like that, my energy was gone. Finally, I only took it 2 or 3 days. I got to Sunday morning. It's time to take the medicine. I thought, if I take this, I'm not going to be able.
You can't preach.
I'm not going to be able to do church. So if I'm going to take this at all, I'm going to take this later. And I thought about it. I'm like, I don't think this is supposed to be doing this. So to my doctor's credit, I call her on Monday and I say, I'm having this reaction. I feel like my life is like the energy for life was just leaving.
Wow.
And she said, we'll take you off that, let's do something else, right? Well, I was talking to a friend of mine who's a cardiologist, and what she said was, I had a patient who was on that same med, who described exactly what you're describing it. Now, to her credit, as her doctor, she did take the person off the medicine, but she didn't quite believe that he was having the reaction that he had. But she did kind of note it in her head. As I said, she took him off it.
Yeah.
But she was like, oh my God, that's exactly what, you're the person. I was putting it into better words probably. But she was like, that sounds exactly like what happened. And so I think, all of our bodies are not all the same across any demographic.
That's right.
Some of these are demographic fictions, but our bodies are not the same. We need responsive healthcare,
Yeah.
both in the design phase and the rollout phase. If you can create a vaccine that people can, ingest in a way that's not a shot, that's as effective or not, maybe not even quite as effective, to sort of get the uptake of the people who are just not going to do a shot, it would be worthwhile to do. Like, I think we have to take humanity into consideration as we're doing this. My last thing. I also think if we want people not to be suspicious, we had this experience a few months ago here in Philadelphia where we had the collapse of the highway. And they got us a functional highway
2 weeks?
2 weeks.
on a road that they've been fixing for all of our lives.
Years.
And what they said was, wow, look what we can do. What I said was, why are we doing this all the time? So when you decide you're going to do a thing, like an mRNA vaccine, when you decide you're going to do a thing, it doesn't take you 100 years to do it.
Right.
So if you want me to be less suspicious, how about you apply some of this wonderful ingenuity and know-how and finances and so on to these other soluble problems that we have? If you want me to trust in your good faith, then apply it to some things other than commerce, right? You have to fix 95 because of the sheer amount of traffic that goes through there and the very near disaster that would have meant from an economic standpoint. That's why that got fixed so quickly.
Yep.
Okay, so how about we care about some other stuff too?
Yeah. Well, it depends on who's dying.
Right.
The
So
sheer
this-
numbers of who's dying.
That's right.
If it's white folks dying, I mean, black folks were COVID dying at twice the rate
Yes.
of white folks.
Yeah, which goes back to my critique earlier about you put the vaccination sites in places
Right.
where our folk could. if you know this is a problem, then you need to find a different solution
Yeah.
to it, and be able to work through that. And I think that that's part of what we're continuing to deal with right now. I mean, I go back, the medical industry, healthcare industry has got to put people over profits, right? I think
Yes.
that's the big piece, right? Second part is actually, if you do it right, you can actually make profits.
That's right.
That's the other part of it too, right?
Both things
That's
can work.
possible.
For those that
two
are
things can happen at the same time.
unfettered capitalists, you can actually make money if you concentrate on this. And I mean, I say this, I actually going back to historical, I actually ran a hospice in Philadelphia, Vista Care Hospice, back in the early 2000s. And one of the ways that we actually built our base was that there were areas in in the city of Philadelphia where other hospices would not go. And I said, that's where we're going.
That's where we're going. There
I
you
said,
go.
I didn't have a fear of going into black neighborhoods. And so, and there was a program called the Initiative to Improve Palliative Care to African Americans. And it was all the same things you were talking about, right? Oh, black folk don't have the same level of pain, or we can't use the narcotics, because people, it's hospice, you need drugs, you need heavy, powerful drugs. And we actually built a base and showed a model about how you can actually provide hospice care with people trusting you.
Yeah.
You need trusted messengers
Yeah.
to be able to get into that
Right.
place, to be able to do the work. And I think that it's a model that we have to look at today. You have to have trusted messengers that are also available, like clergy, like other community leaders, to be able to say, yes, this is what we need to do, this is how we need to go about doing it, this is how we're going to be able to help people be able to, become whole and
Yes.
thriving members of the community.
Yes. Can we talk about our government and the sort of so let's talk about vaccination now, right? If people don't know whether the vaccines are not necessarily free,
Right.
the
That's
booster
right.
is not necessarily free.
Right.
Testing is not necessarily free. Like the good tests, like there was a time where you could go get a good test for COVID that would be reliable, so that if you were having symptoms and the PCR test, if you got a PCR test and it was negative, it was probably not COVID. And now that stopped being the case at some point.
Yeah.
Nobody has $75.
Mhm.
Even people who are middle class like me, I don't have $75 every time Bella sniffles. Bella's my daughter. Who has $75 every time your kid sniffles?
Even the free tests. Where are the free tests? They're expensive.
But they don't have the test for healthcare. My wife's a nurse. Change the
Really?
season allergies, and I kept saying, "Did you take a test?" She's like, "We don't have any tests at the house."
Wow.
And I'm like, "All right." So I literally had to go out and go buy tests, and those tests are not cheap.
No, they're not.
And
Almost $10.
yeah, and I was like, I had to go.
or more than $10.
But I mean,
Depending on where.
she actually works in the community as a community nurse, and she's actually dealing with live people every day. I'm like, how come your company is not providing these tests for you before
That's
you
right.
go into people's houses?
That's exactly
and do the work that you're doing in there. So yeah, I mean, there's a whole thing. How come the government's not providing that for every healthcare worker right now? They know that this is a possibility of increase because of we're in the fall and winter season.
And they're afraid to even say to you, "Hey, put your mask back on." They're afraid to
Oh,
even.
absolutely.
They're afraid
So
even to
politicized.
suggest. Like I'm listening. Literally, I'm reading a news article that says, and they say maybe you should start thinking about maybe
Maybe.
maybe. I'm like,
They're afraid of the
Just
backlash.
say
that,
it.
but
It's become so politicized.
and we
yeah.
no longer. I no longer trust the CDC. In the middle of 2019, if you'd said, okay, there's a global health crisis, who do you trust the most? I would have said the CDC, and not only would I have said it, but most people in the world would have said it.
Yeah.
The WHO would have trusted
Yeah.
the CDC.
Yeah.
So you've so undermined. So I thought we got a new administration that I'd be able again to trust the CDC, and then I watched them make the same sort of political calculations
Yeah.
about things that should have been related to science.
Yeah.
Like what do you think is going on with this virus from a scientific standpoint, and how can we best deal with it? And it was quite clear, and the head of the CDC at the time basically said, we're making a political calculation. We're between what we think is true and what we think people would be willing to hear.
But it's the what we think people are willing to hear piece, that's the piece.
That's right.
Because science is never that precise. So they're out there instead of just saying,
Here's
this
what
is
we do
not
know.
precise. This
Yes,
is what
right.
we know.
And
This
what we don't
will
know.
change.
Right.
Yes, this is now, but this could be, they, if they can stop dumbing down, making assumptions of
I
our
agree.
incapability to understand.
I agree.
We can understand a lot more, but they'd have to put it out there. And then we also all together have to do the work of helping people realize that, I'll say it again, science is imprecise.
That's
It's
right.
always been imprecise.
It's
That's
always
correct.
been.
So
There's
don't put
nothing
it
new.
out there with precision, because that's not accurate.
Yeah.
Well, we face this as clergy. I think all of us on this panel are the sorts of preachers who say, this is what we do know, this is what we don't know. And all of us as preachers know that many, even of our own congregants, would much rather listen to the person who says they know for sure.
Yeah. And we
Yeah. Oh my
Yeah.
God, that's so
And
true.
so,
That's
so
true.
so the challenge though is that if one is going to be a truthful provider
Yeah.
of whatever one is
Yeah.
providing,
Mhm.
including
You
at the
gotta say
CDC.
Yeah.
So then, do I decide I am either only going to say what I know absolutely for sure, which would prevent me from saying much of anything at all, or am I going to try
Mm-hmm.
to figure out how a way to
Try.
provide what is true with some nuance?
Yeah.
We make the decision, all of us, that we're going to try to say what we think is true with some nuance.
Mm-hmm.
I don't know why they can't do that,
They can.
but they
They-
don't.
Yeah.
Yeah.
And so then they get caught in a lie
Mm-hmm.
because it was a predictable lie, right?
Mhm.
We probably were going to have to get a booster. They probably knew that
They
all
knew
along.
that. They knew that all along. Yeah, absolutely.
Things
Right.
related to
They-
the flu shot.
So
It's like
anyway,
logical.
Well, they
so-
underestimate us. They underestimate
Well,
the
yes.
public.
So I just don't want to give them a pass on that. I'm like, I want us to act like adults and do the hard work.
Yeah.
And I want especially, and I'm particularly angry about our government in this way. I want our government in particular to do that. Do the hard work. Offer the. I'm not suggesting that we could go back to mass mandates. I recognize that ship has sailed. People are not willing to do that. But you can actually just say, hey folks,
Probably a good idea.
this is a time to get some masks and go back to wearing them, especially if you are in crowds.
Thank you. To the.
I got mine.
You got your.
I for sure got mine.
I want to thank all of you. Our time is up, and we want to be sensitive to your busy schedules. But thank you so much. This conversation continues for sure. Since as of April 2023, over 1.1 million Americans have died from COVID, and globally, anywhere from a low number, 7 million, could be up as high as 16 million people as of 2023. So the conversation continues, but thank you. I want to applaud you for the great work that you all do in providing for your congregations.
Thank you for having us.
Thank
Really
you.
appreciate it. Yeah,
This is
great.
wonderful.
Right. So